time, I'd like to start us out. So good morning, everyone. I'm just going to go through a couple of ground rules before we begin the webinar, and then we'll get started. So thank you again for everybody for being here. And just a reminder, if you're a parent coach or a parent coach supervisor for the Welcome Baby program, and you have not already, please put your name and your site in the chat. We will be tracking attendance for that group that way, so that's the best way for us to mark you as present. Additionally, I'm going to mute everybody. I have already muted most people, but I'm going to do it again. And that's not to be offensive, but we just get a lot of background noise, so the goal is to minimize that. If you are on your phone, please do not put us on hold because we tend to get your background music that way. So if you're trying to mute yourself on your phone, actually go ahead and mute it. I'm going to do the mute now because I'm getting enough feedback. So 1 second. Okay. Hopefully that covers that. Great. All right. So if you have a question, because you're muted, if you have a question during the presentation, please put that in the chat. And Vanessa Reyes and I from LABBN will be monitoring the chat throughout the presentation. And we'll pull those questions out and make sure that we get those to our speakers during the Q&A portion of the webinar. And then finally, we will be sending out the notes, the attendance lists, and the slides to everybody who registered for the webinar after today. So if you're hoping to reference those, we'll send those out to you later today. Okay, great. So we have a lot of material to cover today. So without further ado, I'm going to introduce our two speakers for today and then turn it over to them so that they can get started. So we have two speakers. We're lucky enough to have two speakers with us today. Dr. Karin Neilsen is a professor of clinical pediatrics in the Division of Infectious Disease at UCLA Children's Hospital, and she's been a member of the UCLA faculty since 1996. She is also an attending physician for pediatric infectious diseases at Mattel Children's Hospital and co-director of the Care for Families HIV clinic at UCLA. She completed both clinical and research fellowships in pediatric infectious disease and obtained a master's degree in public health epidemiology from UCLA. And our second speaker is Dr. Viviana Farajado. She is a current neonatologist at the University of California, Los Angeles, UCLA. She did her medical school and pediatrics residency training in Chicago, Illinois, and came to LA in 2015 to specialize in neonatal perinatal medicine. She completed her training in 2018 and stayed at UCLA as a full-time neonatologist. Dr. Farajado and Dr. Neilsen are both doing COVID research looking at clinical outcomes of maternal-infant pairs affected by COVID. Their extensive research, clinical practice, and lecturing experience make them excellent assets in the fields of neonatology and pediatric infectious disease. We are so lucky and privileged to have them here with us today as they present on this topic. So please join me in a silent but warm welcome for Dr. Karin Neilsen and Dr. Viviana Farajado as they present this webinar titled Supporting Families with a Positive COVID-19 Diagnosis. And I believe you're both muted, so you may need to unmute yourselves when you start speaking. Or I can do it for you. Okay, Dr. Neilsen, you're unmuted now.
Okay, good morning, everyone. It's my pleasure to be here with you today. Thank you for the invitation. And on behalf of Dr. Viviana and myself, I'd like to thank the organizers and Ms. Martha Bach for inviting us today. So the way we're going to do this, I will start by talking about COVID in children, and then Dr. Farajado will talk about COVID in mothers, and we'll wrap it up. So without further ado, let's talk first. Let's see if I can advance my slides here about the virus in question. So this pandemic actually, took us all by surprise. But coronaviruses are not unknown to us. So they're part of a family of viruses called Coronaviridae, and they are what we call in infectious diseases single-stranded RNA viruses. And they have this envelope. And the reason I mentioned the envelope is that this envelope is very sensitive to alcohol and disinfectants and so forth. So that's the whole premise behind washing your hands and using gel sanitizers, because once you disrupt the viral envelope, you kill the virus. The virus has this nucleus, which we call the nucleocapsid, right in its center. It's a pretty large RNA viruses in the family of viruses. Why are they called coronaviruses? They're called like this because when they were first seen in electron microscopy, actually by a woman scientist in the early 60s, they look like a solar eclipse. And the crown of the eclipse is called corona, for crown in Spanish. And what confers this crown-like appearance is these club-shaped spike proteins. You've probably heard of the spike proteins of the virus. It makes it look like a crown. And they're viruses, the class of viruses, they're known to cause respiratory infections. They cause infections in both mammals and birds. And in humans, most of the illnesses caused by coronavirus can range from the common cold to pneumonia. And usually we have three types of coronaviruses that are the ones that cause a more aggressive respiratory disease. SARS virus, which was the coronavirus 1, the MERS virus, which we'll talk just in the next slide about, and the current virus, which is a novel coronavirus, or SARS coronavirus 2, which causes the disease called COVID. When we talk about COVID, we're referring to the disease. When we want to mention the virus, we call SARS coronavirus 2, but people have been using it interchangeably. In birds such as chickens, a coronavirus can cause upper respiratory disease, and in other animals like cows and pigs, they're known to cause diarrhea. So in humans, there are many coronaviruses, and there are some that are only infect birds or other animals. But in humans, there are 7 coronaviruses, and the first 4 that are shown in this slide, this is just to show the common coronaviruses, which we have been identified as early as in the 1960s. That cause the common cold type viruses, and there can either be alpha coronaviruses or beta coronaviruses, and they all cause respiratory infections, usually not very severe. In fact, some children have 6 to 8 coronavirus infections a year because it is a common cold virus. However, we have these beta coronaviruses, which are from the group 2, which are much more aggressive. There was the SARS coronavirus, which caused an epidemic in 2003, 2004. You probably remember it was a very severe illness. It caused a lot of mortality, even more so than the one that we have today, but it wasn't as transmissible. It started in China, then it went to Canada, and it was in the US briefly as well. Then there's another coronavirus, which is the Middle Eastern Respiratory Syndrome coronavirus. It's called the MERS virus, and it's been happening since 2012. There was an outbreak in Saudi Arabia, and the virus has been mainly in the Middle East. It uses actually the camel as an intermediate reservoir, and the camel transmits to humans. So that, and it is very it caused severe illness and a lot of mortality, 34% mortality. So in that sense, it's even more dangerous than the virus we're facing now, but it is also not as transmissible. And then, of course, we have the virus in question, the one we're going to talk about today, the SARS coronavirus. So we live in a very connected world, at least we did until March 2013, and with widespread travel. And this connectivity led to very quick viral dissemination. And that's not true only of this virus, but of many other viruses and other pathogens across the world. So just briefly regarding the early events that led to the current pandemic, the virus was first identified around December 2019, actually on the 27th, when one doctor reported this really unusual pneumonia to the Chinese CDC. 3 days later, there was an epidemiological alert was sent, and it was raised by local health authorities, and the Chinese CDC started an investigation. The virus was linked to a seafood market in the city of Wuhan, China, which is shown, small picture here at the bottom of the slide. And that market was closed on January 1st. 2 days later, the WHO and other countries, including the US CDC, were informed of this outbreak. And very quickly, within 4 days, the virus was identified, and it was sequenced 3 days later. So by January 10th, they knew the molecular composition of the virus. And on the 11th, the first tests to diagnose the virus, which were molecular tests, PCR test kits, were sent to Wuhan, which was the epicenter. Later in January, the virus was added to the list of notifiable diseases across the world. And by the 23rd, the Wuhan city had completely been shut down. And soon thereafter, 15 other cities across China were shut down. So this is how the pandemic first started. And today, of course, this is from the New York Times just recently. We are averaging 100,000 people per day being infected with the virus. This is just a heat map showing the countries in the world that are most affected by the virus. And in the bottom panel, you see the coronavirus cases depicted per million residents in the last 7 days. Week, and you can see the US is still at the top, but there's been a second surge now in Europe with many countries rising as well, and actually approaching US rates if you equate this, standardize it per million residents. So this is a very useful app. It's through the Johns Hopkins University. It's from their School of Engineering, and if you download this, it will show you the number of daily cases, the number of deaths, and so forth by region. So we've had minimally 38 million cases reported, of course, because across the world and even in this country, you know, there's not widespread testing of everyone. This is probably a very significant under-reporting of the condition, but we know that 38 million people have been infected, and there have been over 1 million deaths to date. And I put for you here the leading countries in terms of the number of cases, and in parentheses, you have a number of deaths. So the US is approaching now 8 million cases with over 215,000 deaths to date, followed by India and Brazil, and then Russia in terms of number of cases. And here on the right-hand side, you have the global deaths and also in the US per states and so forth. And unfortunately here in California, we're leading the number of cases of coronavirus, but not necessarily the number of deaths. The number of deaths, New York, because of its early surge in March, April, had a very high number of deaths, and no state has reached that as well. The app also shows you this, this graph with the number of daily cases to date being reported, and also it has another one which I didn't include in the slide, which shows the number of daily deaths for the United States. And here is actually an electron microscopy picture of the virus in the lungs. These are virus particles. They look like Christmas tree decorations lining the epithelium, you know, of the lungs. So this is someone who has severe COVID infection. So yes, there it is for us to see. So very early on, this is from the Chinese CDC, we saw that there was a very high mortality associated with age. And as people older age groups are affected by the virus, the mortality will spike. So as you can see here, in people over 85, the mortality can actually exceed 16%, and in some situations even 20%. So there's definitely an age defining situation in which the older you are, the riskier, the greater the risk to have an adverse outcome from COVID. And one question we have is how many of the COVID-19 cases are in children? And there was a report from the CDC released in April, and this has kind of been standard to now. Less than 2% of all reported COVID-19 cases in the United States have occurred in children. There were more boys affected than girls, roughly at 60-40%. And the incredibly, the vast majority of children have very mild disease. It's seen here, and you can see in this graph that the highest hospitalization rate is actually in children less than 1. This was also seen in China in the early days. So children less than 1 could have more symptoms, normal children, children without underlying conditions. However, most of the children who are affected with COVID have some degree of underlying conditions. And from this report from the CDC, the median age of a child, the average age was about 11 years. And 1/3 of the reported pediatric cases actually occurs in adolescents who are older, like between 15 and 17 years of age. Then 27% of cases between 10 to 14-year-olds, 15% in children less than 1 year, 15% in children 5 to 9 years, and 11% in children of between 1 to 4 years. So that's sort of the background and the breakdown of the infection in children. And we have to remember it's less than 2% of all COVID cases. So why don't children get as sick as adults? So let's talk a little bit about infection and disease and how that happens. It's known since the early days of the epidemic that the viral shedding, the amount of virus that you have in your nose and then later in your lungs, is highest early on when you first develop symptoms. And then that tends to go away with time. And this is looking at both nasal swabs and throat swabs. So when you first start sneezing and having headaches and having all these respiratory symptoms, that's when people are most infectious. So why is it that children don't get as sick as adults? So there are several reasons that have been hypothesized. One is that there's cross-protective immunity. Remember, I spoke earlier that children have several coronavirus infections, especially younger children between the ages of 1 to 5 as they are growing up. They always have runny noses and so forth, and they get not only the common cold coronavirus, but other viruses as well, you know, as they are growing up. And so the hypothesis is that they will have prior immunity, especially a type of immunity we call T-cell immunity, which is what we also call cellular immunity. So when someone's exposed to the virus, a child's exposed, these T-cells have already been, what we say, primed by a prior infection, and they wake up very quickly and fight the virus when there is any exposure. And younger people might still have some of these responses because they were infected not so long ago with these respiratory viruses, while older adults, they see less infections a year, and after many years, these immune responses go away. So one of the possibilities is that children have cross-protective immunity, and that's why we don't see as many infections in children. There's also something interesting in that the virus needs to attach to a specific receptor. It's like a key in a lock. And children don't have as much expression of the viral receptor, which is the ACE2 receptor, as adults do. So even if they became infected at the same level as adults, the disease would be different because they don't have as much virus, because the virus does not have enough receptors to enter. So disease is clearly worse as people age. So these are two mechanisms why they think children don't get as sick, and they're not mutually exclusive. So here is what I mentioned before about the ACE2 receptor, which is a receptor needed at the cell level for the virus to enter. All the viruses need receptors to enter different cells, and different viruses use different receptors. For example, the HIV virus needs the CD4 cell surface receptor to enter into the cells. So the SARS coronavirus 2 needs the ACE2 receptor, and so actually do other coronaviruses as well. And the ACE2 enzyme controls the activity of a specific protein, which is called angiotensin II, and it regulates blood pressure. And every time you have inflammation, this protein can become uncontrolled. And we know that the ACE2, the coronavirus 2, actually affects the lining of blood vessels as well. But this is the receptor, the main receptor for coronavirus 2. And this is from a paper that was published in JAMA back in May, and it's just showing that children have less of these receptors in their nose than adults. And as people age, the amount of receptors that are seen in older people is considerably higher than what is seen in children. So adults have much more receptors for the virus in their nose than children do. They express receptors at a higher frequency. So that leads us to signs and symptoms of the disease. So the classic signs and symptoms of COVID-19, first of all, there might be no symptoms at all, and that seems to be now actually a very high proportion of the population. But COVID can really look like the flu, and it can have a very subacute to a very abrupt onset. Generally, the cough is a dry cough, and people may have fever or feel feverish. It's usually not a very high fever, and most people don't measure it. There's also some reports of isolated diarrhea, which can precede the cough and fever, or it can actually happen alone. Remember, other coronaviruses cause diarrhea in mammals. Children actually may present just with diarrhea, and we'll talk about that soon enough. And the interesting thing about this virus is that for a respiratory virus, it has a pretty long incubation period. Most respiratory viruses, you become symptomatic within 2 days, 2 to 3 days at most from getting this infection, but this virus has a longer incubation period. So in general, people have symptoms within 5 days of the exposure, but it can range as long as 2 weeks. That's sort of extreme, but it's quite considerable considering that the exposure was 2 weeks before. As we know, most people will recover from the virus spontaneously without any specific antiviral medication. But there can be complications, which we have heard a lot about over the last couple of months. The main one is the pneumonia leading to respiratory failure, people needing ventilators to breathe, and actually other organs in the body can also fail. And patients who are very sick with COVID usually have multi-organ system failure, meaning they can have heart failure, they'll have kidney failure, and other to the point that they might die from this infection. So it can be very severe. It is thought to be 10 times worse than the flu in terms of disease severity and mortality. In adults, this is a typical serious situation that we would see. People don't have enough oxygen due to respiratory failure, and they can have all these complications that I mentioned before: acute renal failure, complications in terms of the heart, and with shock and inflammation of the heart itself, arrhythmias. They can have a liver infection, and so you can have a hepatitis with increase in your liver enzymes from the virus. There can be neurologic complications. Patients can have what we call encephalopathy. They can actually have a very high risk of stroke because the virus causes what we call a hypercoagulable state. So blood clots can be common. And with most respiratory viruses, you can also have what we say is a superimposed bacterial infection. So you can have a viral pneumonia and on top of that develop a bacterial pneumonia. That's not uncommon. And as I mentioned before, the coagulation issues. So here you have sort of a normal CT scan of the lungs in an adult, and in the bottom part you have an abnormal CT scan in someone who has COVID. And these are what we call ground glass opacities, as they should not be here on the border of the lungs, as you see. And as the disease worsens, they increase in size to the point that they can obliterate the lungs completely. What is very characteristic of COVID is what we call cytokine storm or cytokine release syndrome. Cytokines are produced actually by T cells, and this actually increases the inflammation and makes the disease much worse. So there's this immune dysregulation. Your immune system does not fight the virus the way it should, or it's trying to fight the virus, but then it can't, and then it sort of starts hurting your own tissue. So this is what we call a very high level of immune activation with release of these proteins induce inflammation. So what happens in children, and how is that different from adults? This was a paper from the New England Journal of Medicine that evaluated children in Italy who were seen in emergency departments. 27% of the children seen in this study from Italy actually had coexisting conditions. And looking at other studies that were reported, like from the CDC in the US early on, it was about 23% of the children. So 1 out of every 4 children who become symptomatic with this disease usually have an underlying condition. But generally speaking, if children have any symptoms, they're mainly common cold symptoms. So they can have a slight fever, cough, runny nose, loss of appetite can be common. And less common, much less common, is shortness of breath or pneumonia, which adults can have. So what do we mean by comorbid coexisting conditions? It's usually the presence of asthma, obesity. We know that a very high body mass index in both children and also adults is associated with worse disease. Underlying heart disease, congenital heart disease is also a problem for COVID. In adults, hypertension is a problem. An underlying lung disease, like for instance, a child with cystic fibrosis could be more prone to having disease. And diabetes is a major risk factor for COVID. This virus really likes sugar. So it not only is worse in people who are diabetic, but it's actually able to induce diabetes in a number of patients. I was actually last night working on a paper, which was a case report of a child that presented with acute diabetes, a 7-year-old, while this child had COVID. So we're seeing more and more cases of diabetes induced by COVID and diabetes made worse because of COVID. So there's a very clear association there as well. So there was a large study from the United Kingdom that showed that gastrointestinal symptoms are very common in children. And this was a study that looked at almost 1,000 children. In general, they were about 10 years of age. That was the average age. These were children of healthcare workers who we know are more likely to contract COVID because of exposure and bring the virus home. And 7%, and that's only 68 children of these nearly 1,000 children who were screened, tested positive for antibodies to the virus. And when they were evaluated, these 68 children, the most common symptom was fever, but gastrointestinal symptoms were actually relatively common, with diarrhea, vomiting, and abdominal cramps being reported. And interestingly, respiratory symptoms were really not very common in this group of children who were studied. Now, there is certainly this group of children who might develop serious respiratory symptoms due to COVID. We've seen those come in to UCLA, and this was a study that was published in JAMA Pediatrics not too long ago, and it looked at children admitted to the pediatric intensive care units, 25 of these units across the country, and they identified nearly 50 children who had respiratory failure because of COVID-19. Of course, this is a small number. If you consider during COVID surges, we've had 50 people, adults admitted to the ICU in one day because of COVID. So when you look at all the PICUs in the country and you find about 50 children in 25 units, that just underscores how rare COVID is really in the pediatric population, at least how its severe forms are very, very rare. But generally speaking, the severity of illness was initially mild and then progressed, and there were 2 children who died from COVID pneumonia. And most of these children had these coexisting conditions. They were considered medically complex children. They might have had immune suppression or cancer. There was obesity. A small number had diabetes, seizures, congenital heart disease, sickle cell disease, chronic lung disease, and so forth. So again, that underscores the premise that generally it's children with underlying conditions that get very sick from COVID pneumonia. And then there are unusual presentations that are typical of children and young adults that are not seen in older populations. One of them are these rashes that you can have on your feet. They're called chilblain-like lesions. And these skin lesions, they can look like hives. They can actually look like chickenpox blisters. And they don't really, people who are completely asymptomatic might have them. They're not really associated with severity of disease. And the most common patient is a teenager who comes in and complains of these purple patches in the feet. They tend to coalesce, meaning join together, and over time they can form blisters. And in about 7 to 10 days, the skin goes back to normal. But the rash can burn and itch, kind of bothersome. And this is actually not an infrequent presentation of COVID. It's the COVID feet in teenagers. Another common finding in patients with COVID is the loss of smell, and loss of smell can lead also to loss of taste. So this has been reported since the beginning of the epidemic, and it's a very characteristic symptom, and it's very typical of COVID, not very common with other viruses. So you can have full loss of smell, partial loss of smell, and something that is the distortion of the sense of taste that goes together with the loss of smell. And we call this in medicine anosmia. And it's usually a telltale sign of COVID, and relatively common in younger patients. It's interesting that this is a symptom that goes on for weeks to months. There have been patients who had COVID in April, and until today have not regained their sense of smell completely. And anyone who has loss of smell or loss of taste that cannot be explained should self-isolate. Now, it's important to explain that this loss of smell or taste is not what we have when we have like a common cold, when our noses get congested and then we can't smell because our noses are congested and we can't breathe and so forth because of this nasal congestion. The nose does not need to be congested. It's actually damage to the nerve cells in the nose, and that's what causes the loss of smell. And so when you have this inflammation from the immune cells attacking the virus, the receptors on our nose cannot detect scent. And for that reason, we lose the sense of smell. And that's very typical of COVID. Now, you've probably heard of what we call MIS-C, or multisystem inflammatory syndrome in children. And this is tied to COVID as well. It's a severe illness. It's fortunately very rare, and it was just identified recently during the COVID pandemic. So this was first reported out of England, and the blue line here that you have on the bottom graph is just showing the laboratory cases of confirmed COVID in the population, and in red you see the number of children developing this MIS-C syndrome. In England they call it PIMS, but here we call it MIS-C, which is this inflammatory syndrome. So you see here 35 children, and this seems to lag behind. When you have a huge pandemic surge, meaning that a number of cases increased dramatically, this happened in the United Kingdom, this happened in New York. A month later, following, it's not concurrent with COVID, it's usually a month after they got the COVID infection, they developed this inflammatory syndrome. And here on the top slide, you can see that the age distribution in England of clinical COVID cases. And as you can see, prior to the description of this condition, MIS-C, there were very, very few children with severe disease prior to these cases being described. Also in Italy, where we know that there was a huge outbreak in April, the Italians also reported this outbreak of this, what we call a Kawasaki-like disease in the Italian epicenter in the Bergamo region of this disease in children. And these pink bars here are just showing you this frequency of this Kawasaki-like disease in children. Now, Kawasaki is a condition, a very rare condition that happens in children, usually less than 5 years of age, between the ages of 0 to 4 primarily, which is a vasculitis and inflammation of the blood vessels. And it's a clinical diagnosis. It's treated with high doses of IVIG, and it's a pretty rare condition. And this inflammatory syndrome, even though it is similar to Kawasaki, it does not meet all the Kawasaki criteria. So what is this multisystem inflammatory syndrome in children? And it's associated with COVID-19 because usually children have this infection 3 to 4 weeks before. And it presents like very high-grade fever for more than 4 days, and any of the following symptoms. Gastrointestinal symptoms are very common. Children have severe abdominal pain. They actually present like they have appendicitis. They might have diarrhea. They usually have a rash, which we call a maculopapular rash. They have redness in their eyes, which is conjunctivitis. They can have changes in their mouth. The mouth becomes very red and blistery, and you have a red tongue, and which can desquamate. You have cough now, and you can have headaches, and children are very irritable. So for people who are pediatricians, they know that many of these symptoms are very typical of Kawasaki, with the exception of cough. Kawasaki, you don't have cough, but the rash, conjunctivitis, oral changes, and irritability are classic of Kawasaki. However, this one can have cough, and of course, Kawasaki, the mainstay of Kawasaki is fever. Is actually what brings children in for this diagnosis, is fever that won't go away, and you can't find any other cause for it. GI symptoms in Kawasaki can happen, but they're not as common. So when you do blood work on these children are sick. They're sick to the point that they require admission to the hospital. And when you do blood work for these children, they have very high levels of inflammatory markers. So their C-reactive protein is very high, ferritin is very high, troponin is very high, the proBNP, they're all inflammatory markers, and this is a condition that needs to happen for this to be diagnosed. And then they can have one of these here. They can have classical Kawasaki symptoms, or they can have incomplete Kawasaki criteria. I mean, they can have anemia, increased white blood count, increased platelets, low albumin, elevated liver enzymes. They can have white blood cells in the urine, and they can have actually alterations in their echocardiogram. They have a reduced ejection fracture, their heart can be dilated, they can have valve inflammation. And this can progress to very severe illness with and even multi-organ dysfunction, you know, so kids can get hypotensive. They might need even to be on the ventilator and so forth. This is a report that came out of New York, and many cases have been reported in Los Angeles thereafter when we had our COVID surges. Now, it's important to explain that this is very rare and actually, interestingly, different from adults who can actually have this too, even though it's rare. Children recover. In most of the cases, if children are hospitalized and receive intravenous immune globulin and are treated adequately and get the supportive care they need, most children have recovered without major sequelae. And this is thought to be an inflammatory, dysregulated inflammatory response to COVID that causes this. It's not the virus itself, but this dysregulated immune response to COVID. And just being exposed, even if a child doesn't have a diagnosis of COVID, like a positive PCR test 4 weeks before, or antibody evidence of COVID-19 infection, if the child has a history of exposure to someone who had COVID with known COVID infection in the last 4 weeks and develops any of these criteria, this child fulfills the criteria of Miss C. So, changing gear here, masks, and we all hear about masks and the mask mandates, and the question is, should children wear masks? And we know that babies, young toddlers, they have small airways, and breathing through a mask is really hard for them. So children less than 2 years of age should not use masks because there's a risk for suffocation. So only children who are able to remove these masks if they need to should be able to be masked. So the CDC recommends that children use masks which are made from household items or made at home from common materials, and definitely never wear N95, K95, any of these respirator masks, because they can get really hypoxic, not get enough oxygen to their brain. But children over the age of 2 should wear masks when in public places. Now, the issue of the schools, which is very significant to families and children too. How safe is it to reopen schools? And we've been living this dilemma on whether to do this or not. Some schools have been reopened in California and in some districts and not in others. It is important for schools to reopen when the community transmission of the virus has come down. So it first should be safe before schools reopen. But many countries in Europe have reopened their schools with success. And all of these target decreased crowding, staggered start times, break times, dismissal times, and reduced class sizes. And in many places, especially in Asia, masking is much more common, and it's becoming growing. The popularity has been growing significantly in Europe as well. Even though children might not be as effective transmitters of the virus, especially young children, they can become infected. And there have been new papers coming out that actually question how effective children can transmit. The general consensus before was that children can't transmit the infection, but this has changed in light of recent publications that have come out. We should reopen the schools because it's important for children to have that experience, to be taught, to be in the company of their peers. Children have suffered tremendously from not being able to go to school, but we have to do it when it is safe. So the question is not should we reopen the schools, but how should we reopen the schools when the time comes. And this is the study I alluded to, which came out in the end of September out of India. And it was a study that evaluated transmission in families in 2 Indian states. As we know, India is a very populated country. And the study looked at almost 600,000 people who were exposed to 85,000 confirmed cases of COVID and actually did contact tracing. And the probability of infection ranged from 5 to 11%, depending on whether the contact was low risk or high risk. And what defines that is how infectious the person was, how long the other person was with this person. Was it a closed environment, an open environment, and so forth. So what they saw is that people usually transmit more infection to someone of the same age. And they did see transmission in school-age children from one child to the other. And they saw, for example, that about 5,300 school-age children infected 2,508 contacts. And they couldn't really see if children were effectively infecting adults, but definitely they were infecting other children. So this has come as a warning that yes, we should reopen schools, but transmission between children is likely to occur when we do that. The other concerning fact that we've learned about COVID is that 40 to 45% of the COVID-19 infections are completely asymptomatic, especially in younger people. And so when you have almost half of the people who have no symptoms and are silent spreaders of the virus moving around, that becomes a risk for everyone as well. And this has been visible through the college outbreaks that we have, as colleges have reopened in September. School-age children might not transmit the virus very effectively, but we know that adolescents and young adults are very efficient spreaders of SARS coronavirus, especially when someone sings, shouts, speaks loudly, they congregate, they stay together. That's why we have seen this surge in coronavirus in college towns as well. So this has fueled the debate of whether, remote learning should be universal or colleges should allow kids to come back to campuses, which has happened in many places. Another question is whether pets can transmit SARS coronavirus 2. Remember, we talked early on that animals are infected by coronaviruses, and SARS coronavirus 2 has been shown to infect cats. It can also infect dogs, but it seems to more effectively infect cats. But there really have been no cases of animal to human transmission that has been documented. And it is not recommended to be testing pets at this point. The pet can get it from us much more easily than we can get it from the pet. Even a tiger in the Bronx Zoo was shown to have coronavirus as well. But they do have the receptors and they can become infected. Another question was COVID-19 and blood type. And blood types, there was some concern that some blood types would be protective and people with blood type A positive would be much more at risk of contracting virus. But there was a study out of Harvard that actually looked at a large number of patients and their blood type. And there was really no association between blood type and inflammatory markers or between disease outcomes. So that was an urban legend and it's proven not to be true. Mental health crisis is a major problem that we are facing in children and adults, families. And in China, this is just an example of a survey done in China where 23% of school-age children reported depressive symptoms and almost 20% of children who were screened reported symptoms of anxiety related to emotional disorders and COVID. And also parents experience high stress levels related to COVID-19. And many of parents who have, adults who have children have much high stress levels related to the pandemic than those who do not. And this was a large survey published by the American Psychological Association. And 71% of people surveyed reported a great deal of stress from managing distance online learning for their children. So that was a major stressor in the life of a parent. So this is, as we balance going back to school and the stressors of working from home, as most of you know, it is very difficult managing children from home and trying to have a full-time job. Extremely hard. And then we should not forget that, as is the case in adults, we have seen a lot of inequities during the COVID-19 epidemic in populations who are disenfranchised. And this is true for children as well. This is an editorial published in JAMA Pediatrics talking about how children have been sacrificed during this pandemic from the loss of educational opportunities. And it's not only education and being with other children, but many children need the nutritional social support that schools can provide, and they have missed out on this because of the epidemic. So children are also negatively impacted if they are from poorer families, and we've seen this as well. Dr. Fajardo is going to talk about transmission, so I'm not going to detain myself into this. The virus can be transmitted from mother to child in utero, but that is extremely rare. That's all I'm going to say about this at this point. There's been case reports of this happening, but this seems to be a rare event. And as the last slide, we should not lose hope. Vaccines will be coming. There are all sorts of new vaccines being tested. This is just an example of 5 vaccines that are in phase 3 trials. They're usually recombinant vaccines where pieces of virus are inserted into another virus to stimulate an immune response. You also have these new vaccines called DNA vaccines that are being developed for coronavirus. And in places like China and in South America and the Middle East, they've been testing inactivated virus vaccines as well. So we should have a vaccine, I would say, in the next 3 to 6 months, which would be available to the population, but there will be many vaccines coming through. And pandemics are not permanent, even though we don't see the end of this in sight because it's a different virus. I believe that with the development of new strategies, there are new treatments available that are proven to be effective, and the availability of vaccines that even if only 50% protective like the flu vaccine, they should still help us in managing this pandemic. So I will end here and we'll switch to Dr. Fajardo, and I'm going to stop sharing my screen.
Thank you so much, Dr. Neilsen. That was so informative. I'll pause while I switch the screen sharing to Dr. Fajardo. If anybody has, and just remind everybody, if you have questions, please go ahead and put those in the chat, and we'll bring those up at the end when we have a little Q&A session. So if they come up as you're watching, please go ahead and just type those in, and I'll keep track of them. All right. Okay, Dr. Fajardo, you now have the screen sharing, and let me unmute you as well. I can find you on my list. There you are. All right, you should be unmuted now, and we can see your slides.
You can, okay, hold on 1 second. Can you see my slides now?
Yes, that looks great. Thank you.
Okay, perfect. So thank you again for giving me the opportunity to talk this morning. Again, my name is Viviana Farajado, and I am a current neonatologist at UCLA. And the second part of this talk will focus essentially more on the evidence-based guidelines for safe maternal and neonatal care during the COVID-19 pandemic. So the objectives for this part of the talk will be as follows. We will talk about the epidemiology of COVID briefly. I will give a presentation about the presentation, diagnosis, and outcomes in pregnancy and neonates, the different routes of transmission, and the question of should we separate mother and baby while in the hospital, or even when they get to the house, when they get discharged. What precautions families will need to take at home, caring for sick household members, and my last piece of the talk will be essentially, how do we talk to children? So as we all know, and Dr. Neilsen did a wonderful job in terms of describing what COVID was. So COVID is a serious virus, and it has killed approximately around 3% of the infected population in the world. And it is about the same percentage actually in the US alone. So again, very contagious, is transmitted via respiratory droplets, though it can be airborne in some circumstances. One person can infect on average 2 to 3 individuals at a time. So what can we do to reduce this transmission? So with appropriate measures such as masking, cancellation of social gatherings, staying at home policies, and universal symptom screenings, we can actually reduce the number of transmissions. Now, pregnant women and neonates are two populations at risk for serious complications related to COVID. Pregnancy just by itself allows for physiologic changes, like in the heart, in the way the pregnant woman breathes, kidney function, and immunologic function. In neonates, they have an immature immune system, so it is easier for them to get infection. Now, a few studies have actually investigated how pregnancy and infancy actually modify this risk associated with COVID-19. This is just a visualization of the infectivity rate of different viruses, and Dr. Neilsen actually touched, on one of her slides about this. So, can you see my? Hold on one second. Can you see my arrow here?
Yes, yeah, we can see your cursor.
Okay, great. So, so these are the different viruses that have essentially caused outbreaks and pandemics. So, if we actually look at the H1N1 in 2009, one infected person could actually infect 1.5. In SARS in 2002, 2003, one infected 3, which is the same as what we see now with COVID. Ebola in 2014, again, 1 to 1.5. And then the MERS virus, actually one person can infect 4.5, people. So the clinical presentation now in terms of presentation, diagnosis, and outcomes in pregnant women. The CDC, or the Centers for Disease Control and Prevention, actually have shown, or they were able to look at their data and saw that in 91,000 women of reproductive age who were infected, there were no difference in frequency of the cough or shortness of breath between pregnant and non-pregnant women. So one of the 3 major symptoms that they were able to see more so in pregnant women is dry cough, fever, muscle aches. And one of the things that was really interesting to see is that around 33% of pregnant women actually have no symptoms at all. So this raised a big concern, which encouraged this universal diagnostic testing for COVID-19 using the nasopharyngeal swabs, specifically in places where the prevalence is high, so like in New York, for example, California. Although the prognosis of COVID-19 infection is favorable, recent data raises concern that pregnant women may be at greater risk for severe morbidities. So they're more likely to be hospitalized and admitted to the ICU. And more severe cases are seen in pregnant women who actually have history of asthma or obese. And then I didn't put it in here, but diabetes is another one. COVID-19, in addition, have also exacerbated comorbidities common to pregnancy, which can actually lead to preterm birth, so like hypertension, preeclampsia. And pregnant women infected with COVID-19 need to be closely monitored because of that. So one question pregnant women will always ask is, would I deliver early? Will my baby be preterm because I've had COVID? And the answer is COVID-19 infection is not an indication for delivery. Well, as doctors and specifically the OB gynecologist will actually again monitor the mother and the infant or the baby, and then we'll decide when the delivery is indicated. So how about babies born to COVID positive mothers? So most neonates actually have a favorable outcome. The incidence is about 2 to 5% in neonates that are born to mothers with COVID-19 positive. One of the complications that we see in the neonatal period is respiratory distress and low birth weight. Again, infants are more vulnerable, and they actually can manifest with atypical symptoms like poor feeding, diarrhea, GI symptoms again, and they can actually have late onset sepsis, which means infection, fever, and actually low white blood cell count. Children are largely asymptomatic, as we heard from Dr. Neilsen's talk, or they can have mild symptoms, as we can see there and as we heard. But again, overall, they have good outcomes. Main things here is that neonates and children with underlying conditions may develop severe complications and are more likely to be admitted to the ICU. In terms of transmission, so what are the different routes in which can a neonate get infected? So this maternal fetal versus maternal neonatal transmission of COVID are central concerns during this pandemic. So one way is via vertical transmission, which means either when the in utero it can cross the placenta. Is it like by blood, mixing of blood? However, this has been shown that it's very unlikely, although rare cases have cases of intrauterine transmission may be possible. There has been cases where they have shown to actually seen the virus in amniotic fluid, in placenta, and actually some babies have had positive swabs at birth. But again, it's very unlikely. These are really rare cases. In terms of can the baby get COVID if the baby's born via vaginal delivery or C-section delivery? Again, the answer is very unlikely. There has been no studies actually demonstrating that they have done vaginal swabs on moms, and there has been essentially no virus obtained from vaginal swabs. The main way, I guess, in terms of transmission is postnatally. So after the baby's born, and this is via respiratory droplets. This is how it's believed neonates get infected. So it's by close contact and not by vertical transmission. So how about transmission of COVID through breast milk? Individual cases have been identified in different parts of the world, like China and Germany. However, when they obtained the breast milk samples for these mothers, at that time, the mothers were not wearing a mask during this collection. So the samples were thought to be contaminated. So the risk is low, and breastfeeding should be supported for all mothers and neonates. As we know, breast milk is important for proper nutrition and immunologic development of the neonate. So again, another important question asked by pregnant women when they come in is, will my baby be able to stay with me after delivery? So the answer is yes. Evidence has accumulated over this month, and guidance actually has shifted from safety preference of essentially separation of mother-baby to one that actually encourages infants to room in with mothers. As long as the mother is healthy, meaning like able to provide and self-care, and appropriate prevention precautions are followed. So in this graph here, This is actually obtained from the American Academy of Pediatrics section of perinatal neonatal medicine. This is a national registry where they actually have looked at around closer to 4,000 mother-infant pairs affected by COVID. And what they have seen is that over time, initially we thought of separating mom and baby will be the best in terms of avoiding transmission. But we now know that starting actually from July, we now know that with prevention precautions that the transmission is essentially reduced. So now we have shifted more towards not separating mother from baby, and then less so of separating them. So if the neonate is healthy and mom has mild to moderate symptoms, the neonate again can safely remain with the mother, while mother is maintaining a reasonable distance from the infant whenever possible. So we know that maternal neonatal skin contact has actually lifelong mental and emotional as well as physical health benefits. So while in the hospital, the recommendation is for infants to remain with mothers. This actually improves mother-infant bonding. This allows for mother to identify her baby's feeding behaviors and actually improve family-centered care. Again, important, infants rooming in with mothers with COVID-19 are not at increased risk. So this is important because this is a question that mothers always ask. So they are not at an increased risk for contracting COVID when proper prevention measures are followed when compared to infants who were separated. So is breastfeeding safe? So similar guidelines have actually also transitioned to encourage breastfeeding. No evidence to suggest that it poses an increased risk that an infant actually tests positive when nursed. So the virus has not been conclusively demonstrated to be present in breast milk. So again, this is also this graph is also obtained from the National Registry, and what we see is that in the beginning we were discouraging breastfeeding. We were telling mothers and families to be separated, and then giving the baby formula instead of breast milk. But now again, July was kind of the month of where we started shifting from that. And now we essentially tell the mothers to breastfeed. So we can see that increase here and less of the formula. If anything, no formula is necessary. Breastfeeding is safe. So what are the preventive measures that we should tell mothers if this is something that they want to do, breastfeedings, right? So main thing is as long as they are washing their hands, washing their breast before each breastfeeding, they have to wear masks during feeds, and if they're at home, they should use a well-ventilated room. So opening the windows during feedings will be the preventive measures that they need to take. So again, COVID-19 mothers should breastfeed, and then they can do this directly or essentially through expressing their breast milk. If they decide to express breast milk, then proper hygiene should be followed, including they still have to wear a mask, they have to wash their hands, they have to wash the breast, wash the pumps and bottles, and so and then the breast milk can be fed to the neonate by an infected caregiver. So one other thing that Dr. Neilsen talked about was, babies do not need to wear face shields or masks. So we have actually seen pictures on the internet about with babies wearing face shields, but this baby should not wear face shields or mask. And again, mothers can breastfeed with proper prevention precautions. So, but I just told you that close contact is the most likely cause of transmission to a neonate. So, the question from mom will be, so what do I do as COVID positive mother at home? Do I have to isolate? What do I do with my baby? So once they're discharged home from the hospital, COVID-19 mothers should isolate, of course, and physical distance until symptoms have improved. They remain no fever for 24 hours and isolated for 10 days since symptoms onset. When possible, maintaining at least 6 feet from her child. Again, hand hygiene, mask wearing when caring for her infant are very important. So what about other household members? So if we think that one of the household members have been, starting to have symptoms, they should get immediately tested. They should also isolate and have physical distance before caring for the infant. So these actually are guidelines from the CDC of how to care for a household member who is actually sick. So again, whenever possible, have that person stay in one room away from other people as much as possible, and have them use a separate bathroom if possible. But what about in houses where the space is limited? So what they recommend is essentially keeping 6 feet distance between the person who is sick and other household members, covering their cough, covering when they sneeze, wash their hands frequently, and then don't touch their eyes, nose, and mouth. Wear a mask around other people, even, like at home. Keep people at higher risk separated, again, from anyone who is sick. Have only one person in the household take care of the person who is sick, and always clean and disinfect all the surfaces and other commonly touched surfaces in the house. Limit visitors. This is important because one of the things that I get asked all the time in the hospital is, can people come and see the baby? I think that during this time, limiting visitors are very important to decrease against the risk of transmission. Not sharing personal items with anyone that is sick, like phone, dishes, bedding. Either mom or whoever is sick at home should not help prepare food. And then again, wash their hands frequently. So how about in extended families, families who actually have large, a big amount or a number of people living in the same household. So one of the things that we have to be careful is that, that older adults or people with an underlying medical condition are at higher risk for severe illness from COVID-19. So if your household includes people in these groups, then actually all the family members should act as if they themselves are higher risk. So how do we protect our household when you must leave the house? So don't leave the house unless absolutely necessary. And if you have to, choose 1 or 2 family members who are not at higher risk to run errands. So 7 things that they have to do is avoid crowds, again, keeping physical distance, washing their hands, not frequently touch surfaces in public areas, always wear a mask, avoid public transportation whenever possible, and again, don't have visitors unless they need to be in your home. So how do I talk to my child, my 3-year-old, about COVID? So conversations essentially with children need to be tailored by their developmental stage. So depending on what age of the child, then that's how we need to approach the conversation. So it is very different to talk to a preschool child to a teenager. So main thing as a parent is they need to remain calm, and they need to be reassured or reassure the children, being able to listen and talk to them, validate their feelings, always promoting positive coping, like reading together. What things can we do to kind of be positive about in this situation? What can we do together, even though inside the house, even though we can't go outside? Staying informed, that's very important. There is a lot of misconceptions out there. So just staying as informed as possible. I know a lot of things change every day with COVID, but being able to keep up with all the information and practicing and modeling preventive hygiene behaviors. It is important to remember that kids learn from watching us, so watching their parents, their teachers, and their healthcare providers. So that is all for our talk. Thank you. And what questions can we take from any of you?
Great, thank you so much. I'm gonna go ahead and unmute Dr. Neilsen as well. Oh, I think you are unmuted. Great. And if you have questions for either of our presenters, please go ahead and type those in the chat, and I will bring them up to them as we go through them. So we did have 2 that came in, so we'll start there, and there may be some more that come in as well. So first of all, thank you both though for that. I think for the most part that answered a lot of the questions that we've been seeing, and I think we have some good advice for how to support our families, so really appreciate that. Our first question is, what is the earliest that the vaccines will be available?
Well, that's hard to predict, but I don't think it will be before the election, as some people are saying. This is Karin Neilsen speaking. There are several that are in phase 3 trial right now. Phase 3 trial is as you know, is a type of trial in which you compare the vaccine to usually either another vaccine, with something called a placebo, an injection of something else. And this is a trial that looks at efficacy. Normally, safety of a vaccine is done in studies, in phase 1 and phase 2 studies. But when if any vaccine had adverse events that were very relatively rare, you need large numbers of people to be immunized to be able to pick this up. And sometimes only after the vaccines are licensed, when you have hundreds of thousands of people being immunized, you can find out if there's any potential adverse event, which is extremely rare. Having said that, it is based on these phase 3 trials where there are 30,000 to 60,000 people enrolled in each one of them. The best estimate would probably be sometime around January, but it could be as much as 6 months. Johnson & Johnson has the vaccine in phase 3 trial, but just halted the phase 3 trial momentarily because one patient developed unusual symptoms. We don't even know if this patient was in the vaccine arm or the placebo arm. These are usually sort of not disclosed. So there are other studies like the AstraZeneca vaccine, there's the Moderna vaccine, many of them which are out there. So efficacy, we only know when, people go about in their daily businesses and they look and see how many people in the vaccine arm received, acquired COVID as opposed to those who didn't. And they test the participants in these studies, very frequently to see if they've had any exposure or, what's the rate of COVID infection in both arms. So that takes a while. But from what I've heard Dr. Fauci say in a number of talks, it's anticipated that somewhere between the next 3 to 4 to 6 months, we should have at least one vaccine available. There are vaccines already available in China. They hadn't finished the phase 3 trials, but they released them anyway. These are inactivated vaccines, viral vaccines. Those are not being studied in the US. The US decided not to study those because they wanted to evaluate more modern vaccines. Sometimes there's risk of complications with inactivated virus vaccines. In Russia, they've also released an adenovector virus vaccine, a recombinant vaccine, prior to finishing phase 3 trials, and that's being given to a lot of the population already. We haven't received from them any reports about adverse events, but sometimes depending on where the studies are done, the results might not be as forthcoming. So I know that the NIH is investing very heavily on this, millions of dollars into evaluation of different vaccine candidates. So based on the estimates, I'd say 3 to 6 months. So,
thank you. Yeah, that's helpful. Since we're on the topic of vaccines, I'm gonna ask the questions that came up in the chat that are about vaccines specifically first. So that's helpful timeline. And now the next question is, what percentage of an effective vaccine is acceptable? So then the participant had 30, 50, 80, like what is the effective, or what is the acceptable percentage?
in our country, the FDA has stipulated that it will not allow any vaccine that's less than 50% efficacious in preventing disease. That's what we have for influenza right now. I mean, it varies year to year, but normally the influenza vaccines are at least 50% effective in preventing illness. Some vaccines can also be in the sense that if you do acquire the illness, you have a much less severe illness. So they're protective against severe forms of disease. And that's true of influenza and of the flu vaccine and other vaccines as well, if you do acquire the disease. So that would be acceptable, but the FDA has already said that they will not accept any vaccine that in clinical trials is not 50% protective. That doesn't mean that the vaccines will only be 50% protective. That's the lowest threshold that is acceptable. That's the lowest bar. We're hoping that the vaccines would provide, better immunity than that. From my understanding, only the Johnson & Johnson vaccine that was being evaluated was a single dose vaccine. It seems like the other vaccines are looking at 2 doses for improved protection, but we'll see. It all depends on the data, because some of these studies, they use different doses and then they compare, efficacy, and that data has not been released to us in any reports or publications yet.
Great, thank you. And then another vaccine-related question. If and when the vaccines do become available, would this likely be a vaccine that targets COVID-19, or would it be more like a flu vaccine with only specific strains?
No, it would be a vaccine that targets COVID-19. We're lucky in that the flu virus is a different virus because it changes every year significantly. It has these properties called antigenic shift, antigenic drift. So it recombinates every year. So the flu vaccines we have right now, they are always targeting the virus that they hope or that they expect will circulate, next year. So they look at the viruses that have reached the southern hemisphere, which is our summer, and then they develop vaccines against those viruses that are circulating in other parts of the world, because flu goes back and forth. Flu is very seasonal, which is not the case with COVID. COVID has not been shown to be very seasonal. So the vaccine being developed against COVID will be against COVID-19, and it should be a stable vaccine that would protect against all different strains of COVID-19, because the virus does not have as much variation at all as the flu virus does.
Great, thank you. And then another question in the chat here is, at what rate of infectivity will the pandemic be declared over?
Well, that's a good question. I think the pandemic will probably be declared over when there are very few cases. Right now, during the epidemic surges, people can, about 10% to 20% of the population can be seropositive. Even after the major New York surge in the epidemic, the seropositivity rate was only 20%. It could be that because patients who have people who have very mild illness don't form antibodies, they only have T-cell immune responses, and those are difficult to gauge. But when the levels start falling in terms of number of cases, and and you have like a over 50% drop in the cases, that would be a sign that the pandemic is being controlled. We're nowhere close to that yet, because cases continue to rise, and they drop a little bit, then they rise again.
Thank you. Those are all really, really helpful questions. I think this next question will likely be for Dr. Fajardo. So the question is, for a mother who is tested positive for COVID-19 and expresses their breast milk, can the breast milk be fed to the neonate by an infected caregiver?
The answer to that is so it should be fed by an uninfected caregiver. However, if the caregiver, like mom, is infected, by following, again, preventive measures like, wearing a mask, washing their, her hands, whoever is feeding the baby should follow those preventive measures, and then then they should be able to feed the baby with no problems. But it should be, this is more for those moms who are concerned that because they are positive that they will essentially transmit the virus to their infants, and their mothers were really scared and really anxious and nervous. So what we essentially advise to them is that they can pump, they can express their milk, and then whoever, sometimes is dad or grandmother, whoever is the uninfected caregiver for the infant can feed the baby. Now, if we have several members in the in the household that are infected, again, the main thing is to follow preventive measures.
Great, thank you. I think that helps clarify that portion. Another question about moms who are COVID positive. Sorry, there we go. For moms that just had a baby, how long is a good time for them to wait before they allow family or friends to visit and meet the baby?
That's a very good question. So, usually, again, going back to that slide where we essentially say the recommendation is to limit the amount of visitors or whoever comes in the house. So we recommend not to have any visitors, again, because there are a lot of people who are asymptomatic and they're carrying the virus, and so the minimum amount of exposures that infant will have, that will be the best for the infant. Now, I do understand that families have family members that would like to come and visit. So again, following preventive measures, wearing a mask, washing their hands, will be the best in these situations.
Great, thank you. I think a follow-up question that just came in, what about if the mother tested positive at some point and then tested negative upon delivery? Should we still encourage the same breastfeeding recommendations?
Yeah, so actually we see this a lot where moms were actually positive sometime during their pregnancy, and now upon delivery, they come in, they get tested, they're negative. Again, the recommendation of breastfeeding is the same. They should breastfeed, and if the mother has tested negative, it's essentially negative, and so we should follow the same as recommendations. So breastfeeding, bonding with the baby, skin to skin.
Great, thank you. I'll see if any more come in, but I had one that I added as well, with just some general advice. So what advice should we tell families that are nervous about their children getting COVID, and how do we mitigate their fears and anxieties while also underscoring the seriousness of the pandemic?
I think that overall, again, it is hard for everyone, not just for those parents who have kids. I actually myself have a 7-year-old, and it is very difficult to explain to a 7-year-old that they can't go to school, they can't play outside, they can't they can't do certain things that they were allowed to do before. The main thing here is being able to, again, listen to them, talk to them, being able to be open about the situation, explaining to them what is happening. And but the main thing is, children will follow. You're the role model for them, right? So they will follow essentially whatever you do. And so I think that for us as parents, we just have to stay calm. And main thing is to be able to be with them, listening to them, and talk to them whenever possible.
Great, thank
I
you.
don't know if
That's a great answer.
Dr.
Yeah,
Neilsen, do
go
you
ahead.
have anything else?
Oh, I see. I think that's it for the chat questions. I want to give you both a big, quiet round of applause. You can't hear everybody, but I'm sure they're all cheering and clapping for you. This was so helpful, and we appreciate you taking time out of your day to be here and present this to us and support our community through this webinar. So thank you so much. I think everybody can see here your emails on the bottom of this screen, but I also will be sharing these slides. So if they have questions, I'm sure they can contact you. I also want to quickly put an evaluation link in the chat. There we go. And I'll send this through email as well to everybody who participated. But please take some time to fill that out. It's really short, but it helps us structure these webinars and be the most support for you. So once again, thank you so much, Dr. Neilsen, Dr. Farajado. We really appreciate you being here. And we look forward to hopefully collaborating with you in the future and getting maybe a positive webinar or some nice things to come from this. So thank you. Really, really appreciate you being here with us.
Thank you for having us again.
Great. Thanks everybody for your time, and we'll all talk later. Thanks so much. Have a great rest of your day.
Bye-bye.
Bye. Bye-bye.